City Health and Hospitals Finance Committee. Today's meeting is officially called to order. Per Section 13 of the Bylaws, committee attendance. If any member of a standing or special committee of the board will not be present at a scheduled committee meeting, the member may ask the chair of the board to request that another board member, not a member of that committee, attend the scheduled meeting and be counted as a member for purposes of quorum and voting. Therefore, Jose Pagan have authorized Ann Williams-Eisen, represented by Aaron Kelly, to be counted towards quorum and to vote on his behalf. Also, I'd like to recognize Sally Hernandez-Pinheiro, who is on a committee member that is on virtually in a listening capacity only. So first, I would like to propose a motion to adopt the minutes of the Finance Committee meeting held on December 4th, 2023. I will poll the members who are here. Dr. Katz?
Yes.
Aaron Kelly?
Yes.
And I vote yes, and so the minutes are adopted. Next, we have one action item for consideration. Mr. Hart, if you could read the resolution into the record, and please.
Thank you. Resolution authorizing the New York City Health and Hospitals Corporation, the system, to execute an 8-month extension contract with Hawkins, Delafield and Wood, LLP, Hawkins, to continue providing bond counsel services related to the restructuring and continuing implementation of the system's tax-exempt financing program for the period beginning December 1, 2023 through July 31st, 2024, under the same terms and conditions of the existing contract at hourly rates set forth. Partners, $465 per hour. Senior associates, $415 per hour. Associates, $390 per hour. Junior associates, $245 per hour. And paraprofessionals, $160 per hour. So this is a request for an extension to continue services in the interim while an RFP is being conducted. Specialized services of experienced bond counsel are needed to prepare and review documents, issue formal independent legal opinions relating to security and tax law and other areas, and to provide legal advice related to the system's capital financing. So it's important that we don't have a lapse in our access to these services. Hawkins has served as bond counsel since 1995 and was most recently selected to continue in that role through a competitive RFP conducted in 2018. The RFP had been conducted under OP 40-58, governing debt finance and treasury operations, which requires presentation to the Finance Committee and approval to the board. As I said, this is an 8-month extension contract that will provide for continuation of services until the awarding of new contracts under an RFP that is being conducted by Office of Legal Affairs. And as noted in the resolution, bond counsel will be paid on a per-hour basis at the existing rates. We are anticipating that total spend under this contract will be well under $1 million. So again, the request is for approval of the authorization, authorizing the New York City Health and Hospitals Corporation to execute an 8-month extension contract with Hawkins, Delafield and Wood, LLP, to continue providing bond counsel services related to the structuring and continuing implementation of the system's tax-exempt financing program for the period beginning December 1, 2023 through July 31st, 2024, under the same terms and conditions of the existing contract at hourly rates set forth. Partners, $465 per hour. Senior associates, $415 per hour. Associates, $390 per hour. Junior associates, $245 per hour. And paraprofessionals, $160 per hour. I'm happy to take any questions.
Any questions? We do have one question from Sally. The Hawkins has been bond counsel since 1995, as you mentioned. Have we ever considered taking them off for a while and trying someone else?
Well, we have, over that period, had several competitive RFPs where we've had competing bids, and they've been evaluated against other firms, and the decision has been made to continue with them. There has been a significant benefit from the experience that they do have with our program, and we've been very happy with their service over time.
Okay. And other than when you're doing a transaction, they provide other services periodically. Is that why we need to have, it's not just for
Right, so
transaction.
things like arbitrage analysis, and just general inquiries that we may have if we're considering different options, we may reach out to them just to understand if there are questions about covenants, sometimes renewal of some of our letters of credit or remarketing. We talk to them in terms of the terms that are being offered.
Great. All right, just make sure no other questions. Great, so thank you for the presentation. So I'll poll the members for their vote. Dr. Katz?
Yes.
Erin Kelly?
Yes.
And I vote yes, so thank you. The resolution is approved to move forward to the board. So this month, we actually have time for our financial update. Thank you, Linda, for that. And John, I'll turn it over to you and the team to take us through.
Sure.
what's going
Sure.
on. Thank you.
Well, it's great. Thank you for making time for us today. We last met, I think, in December and reported on November data, which at that point I think we're about break even, maybe less than $50 million. To the good versus the budget. I think at this point in the year, we're seeing kind of the same results, about break even. And I'll go through the managing the risks and the headwinds. But through December, right, we closed December with $500 million or 18 days cash on hand, which is about usually where we end the end of the year. January, it's looking about $600 million or 22 days. Cash on hand, again, consistent with where we thought we would be at this point in the year. Moving to managing the risks, these are basically, the same risks that we keep tracking. I think the color coding is the same, but I think maybe more on, there's been some improvement, which we can discuss here. The first is on staff recruitment and the nursing glide path. We spoke about that. We set forth a glide path over the next 18 months where we're want to shed the more expensive contract nurses and bring in our own nurses. And we implemented this all hands on deck approach, which we think has been pretty successful, where we got central office folks together, finance, nursing, and HR. And we've kind of paired ourselves up with our counterparts, in the facilities to try to, again, make some movement around, hiring our own staff. And the themes were recruitment, retention, and then the other, element here is to the extent that we can attract nurses that have been with us for some period of time that are currently on contract, to health and hospitals, we're inviting them to join us. But to date, right, we're 652 full-time, part-time RNs that we've actually hired, and I think that's probably better than the glide path. So again, we'll keep tracking this. We did do something similar for non-clinical temps, right? We don't want to ignore the non-clinical staff as part of moving more towards our own H&H staff. So we had the equivalent of an all-hands-on-deck meeting there last week. And now we're starting to, focus our attention on sessional spending. We saw a spike in sessional spending really over the past 18 months, and we're working, again, with the facilities to implement various strategies to put better controls on sessional spending. I mean, sessional spending by its nature is a very useful tool to the extent that, we're trying to use that as a means or a bridge to hire our own, provider workforce, or if there's increases that we see as it relates to higher volumes, especially as we enter the COVID flu months. So you have to look at that and analyze those trends very carefully. But we do feel like there's room there, to control sessional spending back to the budget levels. And we set the budget based on FY22 actuals. But more from us on that. We have a meeting again with the facilities and clinical leadership at the end of the week. So we'll let you know how that goes. As we had mentioned, right, we, like other healthcare systems and I guess the economy in general, a lot of, significant inflationary pressures. I would say more so, I think the healthcare sector has really proportionally experienced the brunt of inflationary costs, but we've had those factored into our plan. As part of that, as you may recall, we did put in place a $90 million savings target where we asked the facilities to come forward with their own plans, and they did a very nice job developing their own initiatives. We track those when we meet with them every month, and I think for the most part, they're all taking it all very seriously and on track, right, to meet their targets. But we'll keep an eye on that. City-state budget, continues to unfold. The state will be releasing their budget, and so will the city within the next, couple of weeks. So we'll get a glimpse in terms of, both the city as well as the state in terms of how they're planning on addressing their own respective financial plans. We did submit the fourth PEG, and it's being evaluated by OMB. Our plan, I think, was another solid plan. It hit the requested savings amounts requested by OMB, and that will all be factored into the January plan and released here very shortly.
So,
Questions?
if I can just pause on a couple of things here. So the 90 million in gap closing was prior to all the PEGs, or just?
Yes, it was part of addressing either PEG 1 or PEG 2, right? So it was part of our overall development, knowing that we were going to have to make contributions there, yes.
Okay, so but now this is we're working on or just submitted another.
We're on PEG 4.
Got it.
Yes.
That's the January one. And then just going back for a moment on the nurses, we did have a question from Sally on the transition from agency nurses. So obviously the reason we're transitioning to get to full-time is because it's more costly for us and we're, quote, in the red. How much is that in dollars in terms of the temp staffing for nurses, and how long do we expect to be, I guess, over budget or in the red?
Sure. So some of that overspending is offset by our vacancies. So we estimate that the overspending for FY24 is about 79 million. And we do expect it to go down next year. We can get you the number for that, but we expect it to go down pretty significantly.
Okay. And 79 is considerably lower than FY23, right?
And that's with the vacancies offset. So
79 is with the
the net,
vacancies.
yeah, that's the net.
That's lower, yes.
It is lower
That's
from
higher.
20. I mean, we're moving, as you
Yes.
said, the glide path is
Yeah.
we're gliding.
Exactly. There are a lot of improvements that, on the nursing side, our, Dr. Sinis has been pushing
Sorry,
for,
and that's
include,
179 million.
Right, I think that's,
179 million.
including like the reduction of our rates and all these components, and transitioning to full-time nurses is definitely a great thing for our system. So it's definitely less costly, but also allows for the
Stability.
stability. So
Right.
this recruitment post NISNA has really been
And very
very
important.
beneficial and important for the system. Yeah.
Do we have a target for, like, what's we wouldn't ever be 100%?
yeah, so I
full-time,
think
right?
just
Is that-
the numbers, I mean, the numbers were very, significant, right, at the high water mark. But at one point, 20% of our nurses were contract nurses.
20%.
Yeah, 20%.
Wow.
Right, and the cost difference between our own nurses versus the contract nurses, obviously it fluctuates, significantly.
Mhm.
With the market, plus, and then we believe, right, and this is bearing to be true, is that once we establish the NISNA contract, right, it put us to be more competitive in the market.
Mhm.
So I think all those things, working together. But in answer to your question, the model that we utilize, for staffing purposes and budgeting purposes, we think our kind of sweet spot there is about 5% of nurses being contract nurses. Now, we're shooting for that target. I think the other thing that we got out of this contract, and we're grateful for this, is more flexibility with the workforce, right? So if we can be more flexible with our own workforce and establish float pools, right, to meet the demands of a particular facility or borough for that matter, right? We can deploy our own resources
Right.
more effectively rather than locking in on more expensive contracts for likely a longer period of time. So that flexibility, I think, was one of the great things that we got out of the NISNA contract, and we're again trying to deploy different ways to use that flexibility. But the number,
Conceptually, what we want is to use registry for what registry was meant for, which is unexpected temporary lapses. So someone is on family leave, somebody's on disability,
Right.
right? That's what you want registry for, right? Because you're going to give them back their job when they return from parental leave,
Right.
right? So you need somebody to do their shift for the next 3 months. You don't want to hire somebody. That's what registry is supposed to be.
Got it.
Right. What it became because of our salary structure was temporary
couldn't
nurses working for 4 years.
Right.
And we have such, it's not their fault.
Yeah, yeah.
Right. But now we're like, no, we don't want to, have temporary nursing for 4 years. We want you to either commit yourself, or we're going to find somebody who is willing to commit themselves
Right.
to health and hospital. So
Well,
I
it's
think
probably the combination of that plus the surge, right? The surge,
Sure.
And then it just get into a pattern. Of-
right, we just couldn't ever get back to,
Right.
but now we are.
Yeah.
So it's very impressive, and it's good for everybody's morale.
Yeah.
Right, it makes people who are not committed to your organization, right, don't help the morale of your organization.
Right.
So things are much better now.
Yeah. I mean, not just the financial side, but obviously the operational is huge.
It's a huge difference.
Great. Thank you.
yes. Federal budget, yeah, so and I think that's where I left off. The dish cuts, right, were delayed until January 19th, so we'll keep our eye on the next CR from, Congress, or how they decide to deal and address the budget. And we've looked at the IPPS implications of the rule, which does have a negative impact, but it's not material. Medicaid research, I think we'll go through some of that here. We feel like we're doing a pretty decent job on the Medicaid research. December, a big month for us in terms of how the research plays out. But I think between the work that we're doing with ourselves, Metro Plus and Health First, we feel like we're in a pretty solid position there.
Great.
Hi, good morning, everyone. I'm Allison Hartman, Revenue Cycle Services. I'll be covering some content today for Margie Carlin, who couldn't be with us today. First, we wanted to touch on some efforts within the department to try to find ways to use technology to continue to innovate and address our various work streams. So here we're calling out both some works in progress and some initiatives that are in the pipeline that I'll just run through relatively quickly. So works in progress, we have some work ongoing around predictive denial analytics, really trying to leverage data to ensure that staff who are assigned to work denials are working the denials that are likely to have the highest yield for us, so that we're using our resources effectively. One-stop benefits, here we're trying to leverage some big data to try to accomplish what we've been working on for some time around trying to leverage the interactions that our financial counselors have with our patients around health insurance and financial assistance enrollment to help them enroll in other public benefits that they might be eligible for, but in the most streamlined way possible. Documentation analytics for missing charges, similarly leveraging big data to try to identify services that we may have performed but did not charge for, and then use that analysis to implement the front-end strategies to ensure we're capturing all of our charges. And then our Experian implementation, this group graciously approved a new contract with Experian, which we're looking to implement in the early summer, which we're anticipating will include functionality around enhanced claim status, denial prioritization, and improvements to our insurance capture workflows. Some other items that are in the pipeline, but just not quite as far along, are autonomous coding, leveraging AI for scanning and indexing, leveraging generative AI to respond to billing inquiries and to draft appeals, and expansion of our robotic process automation to include additional use cases. Next, just wanted to touch on our Revenue Cycle Institute, which does continue to expand its reach. In FY23, we had 184 courses offered by the Institute, over 10,000 class completions, which is really a great achievement for the Institute. And our retention data does suggest that our rollout of the revenue cycle new employee onboarding training has led to improved retention of employees. You can see in the chart on the bottom right there, continue to analyze the data, but when comparing employees in revenue cycle titles who have and have not participated in the new employee onboarding training, we do consistently see a higher retention rate for those who were enrolled and participated in that training.
Allison, is the training, if it's onboarding training, are all new employees now going through that training? Because clearly it seems to be more effective in keeping our folks here and productive.
Yeah, at the moment, the new employee onboarding is strongly encouraged, and all efforts are made to enroll new employees into it. It's not mandatory, but we are exploring mandatory enrollment into it.
Yeah, I think so. I think we've been talking about this a while in terms of like how we can, leverage the Institute, particularly for new employees, right? Not only are we trying to teach them, make sure they understand all the vast technical knowledge, it also gives us a chance to kind of introduce them to our culture.
Yeah.
And I think that is, something that we think is very important. It's just, as we need to grow the bandwidth of the Institute, which is, again, I think we've done a pretty good job over the years, but I
So
think
the Institute is all in-house, right? It's in-house.
well, in-house with some contract help.
The courses themselves, the live instructor-led trainings are all in-house, and then we do have a vendor for e-modules that are also available.
Uh-huh. And like how extensive is the training? Is it over months or it's like a week or?
It's several months. It's really a series of classes that are offered, some really before the individual starts really performing their function, and additional ones staggered along the way, which the team has found, allows for better absorption of the material given folks are sort of getting their feet under them, and can take better advantage of some of the classes after they've already been performing their function for a little while.
Right. I mean, I just look at, obviously this is not, it's just 1 year of data monthly, but at 50-60% turnover rate for people who are not enrolled in the class, it's
Right.
quite disruptive, it
Yes,
seems.
it
And
is.
so it would be worthwhile to take the time to have that be mandatory training to keep them in, and it helps them to become more effective. And you say, I think culture building is a really important part of that too.
It does, and I think, again, we haven't gotten there yet, but I think you could kind of also consider linking the completion of certain training and modules to advancement.
Right.
So we're trying to get to that point too, where if you invest in us and go through the different steps, and we invest in you, right, because this is all, pretty esoteric knowledge, but also transferable.
Right.
We'd like to try to take that next step and build it into our, progression or advancing staff.
Yeah, I mean, it goes sort of with even like the nursing, just the more people you have that are committed
Committed to you.
Right, committed to the organization, the better. Great, thank you.
Next up, we did want to provide an update on our recertification results. We're approximately halfway through the unwind period now, and our results do remain in line with our H&H financial plan assumptions. For the cohort of our patients who were due for recertification from June through October, we're right now averaging about 80% of that group having recertified their coverage for our biggest health plan partners. You can see that in the chart on the bottom. We're showing here Metro Plus and Health First recertification rates compared to our financial plan assumption of 75%, as well as some goals and stretch goals we've set for ourselves as we try to continue to optimize and ensure we're getting the best results possible. You can see during this time period, the recertification rate for Metro Plus Health members did trend down ever so slightly, which we believe is primarily attributable to a lower recertification rate for certain immigrant populations. I will touch on the next slide that in a little bit more detail, as well as some strategies we in Metro Plus have implemented to try to address that. And finally, recertification rates for New York City residents are in line with, if not slightly beating, the rest of New York State, which is really great to see. particularly as our patients represent such a significant proportion of the New York City population.
Can I just make sure I understand this chart? So right now, through October, we're averaging about 80%. That's what it kind,
Yes, exactly.
okay, but then with the projections for November and December being much lower, you think we're gonna drop below or won't? Or
Oh,
we
so
won't?
November and December, the slightly lighter color really just indicates that those months haven't fully matured yet. Individuals can recertify through the end of the month following when they're due for recertification. So those who are due for recertification in November, for example, had through the end of December,
I see.
and there's still even a little bit of late renewal
So
activity.
you actually expect we might be higher.
Yes.
We're gonna get above 80%, hopefully.
Yeah, I would expect November and December to be similar to the previous months.
This previous months and potentially getting even closer to our stretch goal.
But the way the chart looks, we're not getting closer to the stretch goal. I guess because every month, it's not really
It's not
cumulative.
cumulative. The chart doesn't
Right.
give you cumulative. I can't do the
Right.
math in my head
Yes,
to
it's
see.
not cumulative. It's like every month, a new group
Right.
is eligible.
Yes.
And then you're just seeing the variety, you know, that at the beginning you got 81%, now you're
Right.
getting 74. There's probably some trend to people who do it at the beginning are more likely to do it ahead, and then you're getting more of the laggards who are later and therefore less likely to succeed. But is if we do not get to your goal, which is okay,
Mhm.
but is that a substantial amount of money?
Well, our plan has 76? Yeah, 76.
Because this makes it look like the plan is 80 and the stretch is 83.
Well, we're targeting 80.
We're targeting 80.
I see, you targeted, but you didn't budget 80.
Yeah, we're a little bit lower.
I see,
We budgeted at the red line.
The red is, yeah.
Right.
financial.
I got it. All right, so we'll be, financially, we'll be okay either way.
We're doing okay now.
Got it.
Yeah, I think so. I think December isn't, so I always get concerned about December because it's the month where the SSI population, and there's a bolus of others because SSI, for whatever reason in the cycle, is.
There are, yeah, the December cohort, just in terms of numbers, is the biggest. So it will have just, the most significant impact on the overall rate, but we're not really seeing anything different about the December population in terms of their recertification rates at this point.
But the concern we do have is the SSI population that's done on paper, right,
Mhm.
with HRA. So there's this cohort that's obviously very important that we, don't break care with them because they're SSI disabled. So it's imperative that we keep the connection with their health insurance so we don't lose the clinical connection. So we've been, talking to Health First and Metro Plus about different strategies we can employ there, and even talking to the state. Obviously, they don't want us to lose that cohort in the enrollment process.
I
But they're done on paper because it's complicated, so.
So they can't do it online, is what you
Yes,
mean?
yes.
And they come up in December.
They come up in December, but the state has the option to, push that date out. And our hope would be that if it doesn't look like we're capturing the numbers that we had hoped, that we would go back to them and just push it out another month and try again. So we just have to keep our eye on that.
I would guess, John, that the SSI is a sort of bimodal population. That those who have medical illness.
Yeah.
You're likely to get them because they're going to be coming.
Right.
Right. The problem will be the people of SSI based on a behavioral health diagnosis who often avoid care, right, unless it's, that they're brought in by to PES.
Yes.
And then, of course, they're not in a position where you can get the documentation either, so it's a little
Yes.
challenging.
Yeah. So we'll keep watching that group, right? Other states have done presumptive eligibility. We just kind of assume if they're on disabled status, they'll more than likely still be disabled. That's the way it works.
Right.
So we'll.
That I think is safe.
Yes.
I think, right, the data on people going off SSI based on no longer being eligible is very small.
Yes.
And is there any thoughts or, oh, well, actually, it's reversing in November and December so far, but it looked like Metro, Plus is declining a little bit over the months? Is that,
Metro Plus is trending down a little bit. I'll actually touch in a moment on, we think it primarily has to do with, they have a significant immigrant population, and we are seeing some individuals who enrolled during the PHE when documentation requirements were eased, who now, when they come up for renewal, have trouble producing documents to show a qualifying immigration status. But both we and Metro Plus have done some work around educating our staff around what documents to look for so that we can really try to work with that group and allow them to renew whenever possible.
But it could be that the best review will not be able to eligibilize them, right? That it's not the fault, right? If Metro Plus disproportionately has people who were able to be enrolled at a time when documents were not looked at because of, right, I mean, we're Health and Hospital, right? So we're the natural group that's taking care of those people.
right,
If we could enroll them at a time when it seemed like maybe they were eligible, but now we can't, we will lag behind, and that won't be our fault.
right.
Right. So we're trying to optimize, but totally possible that the lower rates we're seeing in the more recent months will continue to be the baseline for Metro Plus.
Yeah.
Thank you. Sorry.
On the next slide is where we dig into just a little bit more detail. So first, just to again demonstrate the magnitude of the effort. Again, we're about halfway through this. For that period from June through December, we did have 243,000 managed care members who were attributed to H&H due for recertification. And we've seen, again, a pretty solid success rate with about 153,000 having renewed so far. And for those months where, we consider them fully baked, the individuals have had a chance to recertify through the end of the following month, we're seeing about an 80% success rate. Our current focus really continues to be having both our centralized telephonic financial counseling team in collaboration with our health plan partners, try to proactively outreach to members who are due for recertification. That's just an ongoing focus, and we are testing some new tools currently to try to improve our success rate of trying to complete those more complex, for example, the HRA or SSI renewals that John was just mentioning. Over the phone, because they're paper intensive and have not really lent themselves to being completed over the phone, but we're testing some strategies to try to improve that to avoid those individuals having to come into the facilities to renew. Our facility-based financial counselors continue to be focused on helping patients who have upcoming care appointments or who do need in-person assistance to try to leverage the fact that the patients are coming in for care as just another opportunity to try to help them renew their coverage. We touched on this a little bit already, but one of the headwinds we're facing is just the size of the December cohort due for recertification. It is almost 2 times the size of the other months on average. So, but we've been able to flex our resources, the health plan resources, to still maintain that proactive outreach to this group. As we had also touched on a little bit, certain immigrant populations are not eligible upon renewal because they cannot produce that documentation to support a qualifying immigration status. But we have done some education and scripting for our financial counselors within H&H, and Metro Plus has done the same for their representatives. And that does include referrals to a legal health attorney, where maybe the patient can't produce the documentation right away, but in working with an immigration legal attorney, they may be able to produce that documentation. And then finally, the upcoming, although it has now gone into effect as of January 1st, expansion of comprehensive Medicaid managed care coverage to undocumented seniors age 65 plus. While much of this is automatic, we are leveraging the same team who's responsible for recertification to proactively outreach to patients who may not already be enrolled, but who may now qualify for this. So it's just a little bit of another example of where we have to stretch our resources to be able to do that outreach.
Could I maybe we'll take a minute on the one-stop benefits. We talked about it just here briefly. We're excited about this. This is a new area. You know, as we know, as we go through the eligibility process and the exchange for healthcare insurance, our financial counselors gather a lot of information. And the idea here is, you know, can we take that information and also apply it to other benefits that the person might be eligible for, right? Because they're making quite an investment of their time to give us this information to get health insurance. If we get a little bit more information, can we qualify them for WIC or for housing? And you know, the studies out there show that if you get one public benefit, right, there's about, I think, like $50 billion in other public benefits that you're eligible for, kind of left on the table. And I think we're well positioned, right? We have financial counselors that have been doing an exceptional job, and I think are interested in trying to do more, trying to leverage, you know, technology, and as well as you know, it has major VBP implications, which I think is a nice segue here, right? Where they're looking at the hospital not so much just for their healthcare services, but for the full range of you know, social
Wellness,
determinant
right,
services that they can capture. So we're excited about it. We're thinking about, I think WIC is first to get rolled out, and we'll see how that, you know, plays itself out. But we're trying to connect different silos of government data and organizations, and you know, if we can bridge those, we think we might. We'll see.
So when you're speaking of that, John, you're saying sort of expanding the training of the financial counselors
Yes.
to be able to think about all the different pathways.
Exactly, which they're pretty excited about, right?
Right.
I think it gives them something new to engage with, you know, our future enrollees on. And it fits nicely, again, with VBP, and,
Right.
you know, we've talked a little bit about it with Metro Plus, and mentioned it to Health First, because it all kind of, you know, fits together. But it is challenging, right? Because you have all these different rules and different databases with different protections on those databases. But again, we feel at Health and Hospitals, we're very well positioned, just, you know, given kind of where we are and the infrastructure we have in place with our financial counselors. Just need to expand that a little more.
So does this activity, leverage Epic? Is that?
Yeah, it leverages Epic and, you know, financial information that we're using to qualify the person, you know, for health insurance. Some of that information carries directly over, and you just need to gather a couple of other pieces of data to, you know, fully determine whether the person is eligible or not. And the artificial intelligence is gathering all this data, and at this point just making a prediction. We think this person would qualify given all the other information and demographics that we have.
Right.
But eventually we'd like to actually, you know, build it to the point where we can, you know, actually grab data and actually do the actual application for the person when they're there. Yeah.
Interesting.
So, yeah, we'll let you know how that goes. But again, I got to say, this artificial intelligence really opens my mind.
Right, it speeds up everything that you're capable.
Exactly. In a very short period of time, people are coming back with all this, I think, useful data.
And are you able to track some of this, you know, that you're taught to connect the links, you know, from, say, getting people back re-enrolled, recertified, to, say, VBP outcomes?
That will be our goal, right? We know, right, the literature tells us that, you know, one of the things you can most do to improve somebody's health outcome is make sure that they have housing and food and, you know, the basics. So, yeah, but eventually hopefully we'll be able to track all this.
That's great.
Right. So,
Thank you.
And getting people food is another kind of income assistance.
yeah.
Right. So even if they're not suffering from, you know, food insecurity, if you help them to pay for food, it would be the equivalent of giving them economic assistance, which we know has a huge benefit.
Huge, yes. Yep. So we'll keep you posted on that. We're doing VBP priorities. I think Megan also has the bug, so a lot of us are dealing with the bug. Margie, I think, as well.
Is everyone sick?
We could either hold on this for the next session, or I could do my best to kind of explain it. It won't be as good as what they do, but yeah.
I mean, I'm happy to hold.
Okay.
For the next.
I'm sure they spent a lot of time on this.
It's very interesting. I mean, I did get a briefing on it, and so I think it's worthwhile to hear the detail, because it's very, it's what we're really moving for.
Exactly. And I will say that, you know, when we meet with the facilities every month, you know, a significant part of our discussion with them is VBP performance.
Yeah.
So we're really trying to get more intentional about that, and that's the work that they've done here, so.
Great. I mean, if you have any other comments on VPP, Mitch, or,
It's just that VBP is clearly what we should be doing. There is the cultural problem that for many years people were pushing productivity, which is not a bad thing either.
yeah,
Um,
it's the
and-
balance.
Right, so, right, you want people to be seen and to have the visits. It's just that you don't want that to be the driver. You want population management to be the driver of the visits. And so, it sort of requires a change in culture, which, as you know, is always harder and longer. It's not as simple as sending out memos, especially if it's been drummed into people, see this number of patients, right? And then this is really, yes, see that number of patients, but the ones we want you to see are the ones who haven't been seen, who have a care gap, right? So, and that requires both better data and a different mindset. I mean, even very good doctors are used to the idea of, well, if the person doesn't come, the person doesn't
Maybe
come.
fine, right?
Right. I mean, that's not an unusual, and it's not totally wrong either, because people are allowed to make choices.
Yeah, you can't force people.
You can't force people, and people. Sometimes what a doctor thinks is important is not, in fact, the same thing as what a patient thinks is important. Right. I mean, the classic example is colonoscopy. Where we think, if you have a positive fit test, you really need a colonoscopy. But a lot of people really don't want a colonoscopy. And, you get into this, how hard do you push? Do you ask them once? Do you ask them every time? What is your message? Most people who have positive blood in their stool and who you're going to ask to do a colonoscopy will not have serious disease.
Really?
No, most people will not. Most people will have a hemorrhoid or something really minor. But the point is, the percentage who do have something serious enough
It's very serious.
is high enough that the doctor says, right? Just like most people admitted for a heart attack don't have a heart attack. You admit people, right, because of the likelihood is sufficiently high, right? Doctors are focused on risk, right? Someone has a 5% risk of dying. That's, for a doctor, that's huge. For a person, that means there's 95% chance they're fine. So there's a very different mentality. And so all of this is just to say that, this is the work, and it's not unique to us, although we are taking care of a group of people who have more other issues going on at the same time, and who therefore may not be able to prioritize their own health in the same way that patients seeking care in other institutions might be able to do. And so trying to figure out the right balance when someone says, I can't do that because I can't take off from work. I don't have anyone who can take me to that procedure. It's very different than when you're working with middle-class populations, and there's always somebody to take them, and there's always somebody, they have sick leave, and it's how you help somebody weigh if they don't have sick leave, or
How important
how
is-
you help them
Right.
to figure out who can take them if they don't have someone. It's just it's our population requires a different level of thought. But clearly, VPB is the right thing for us. We don't want to be about, churning visits.
I probably, what is our percentage mix now of VBP?
Do you guys know that? I mean, the number that I keep in my mind that's really a fixed budget for health and hospitals is about 60%, right? But that takes into consideration anything that's capped, meaning certainly, risk pool
Mhm.
performance is within there.
I see.
Uh,
You're talking about, so the dollars.
Yeah, the
wise.
dollars are capped, right? So again, you operate differently if you're operating as a fee-for-service organization where you're, right, trying to churn visits, right?
Right.
Plenty of very successful healthcare systems, that's the way that they operate. For us, it's about 60% is fixed, which again would include dish dollars as well as risk dollars, and I guess I'm going to that UPL. So, and again, we're trying to turn that more 60% into a higher number,
Mhm.
right? By either, capturing more enrollment membership or even engaging in different relationships, with our insurance partners. But the number of individuals we have under risk, do you guys know that number off the top of your head?
Not off the top of my head.
Yeah.
but-
Okay, that's
Yeah.
fine.
The other complication, which again everybody is dealing with VBP, is that you would think, okay, so it's value-based payment, so I get no higher payment for seeing the person more. I should focus all of my effort on taking care of them better. So as many phone calls or
Email.
or email, all that is great. No, because the rates set for VPB are based on utilization of services.
Oh, I didn't.
Yes.
Hmm.
And it's sort of unavoidable because think of yourself for a moment as a taxpayer
Mm-hmm.
for the bulk of our patients of Medicaid or Medicare.
Yep.
Do you as a taxpayer wish to pay more than the cost of the care?
Mm-hmm.
Probably you don't. Probably you'd say, no, I want to, I'm a good person. I want to help out people who can't get health care. I'll pay whatever their cost is. Okay, well, how do we prove what our cost is? So our cost includes those things that generate cost, like visits, but not things like, email or phone calls. So it's a little bit circular that you wind up a little bit back to having to show your productivity, even if that isn't what the person most needs. One general solution is to try to be better about diagnoses, right? So that you're documenting their severity, and then their severity should include the idea that I would reach out. But even that, many of the VBP plans, if you don't redocument their disease periodically, then the diagnosis falls off.
Away. Mhm.
On the theory again that, well, if they had such a serious diagnosis, why aren't you seeing them? And the answer is because many things we don't need actually to see people to do, right? We need them to do certain things, but it's just another way of saying it hasn't all, right? The world, again, this is not our problem. The world hasn't really figured out how. Another way to think about it is what went wrong with the first rollout of managed care. The first rollout of managed care was incredibly unpopular because the feeling was that managed care plans benefited from seeing you as little as possible. And denying you things. Right. So that was managed care 1.0. You're in managed care, it's going to be cheaper, but we're going to say no to everything you need.
Want to do, right,
Right.
or need to do.
Okay, so people hated that, right? So then came the idea, well, okay, so, that's not what we want. We want some way of, getting you the value-driven things that you need. But then not everybody agrees on what are the value-driven things. And so visits go back as one of the elements of need.
Isn't health or the
Yes, but sick people, most of medicine doesn't change illness. Unfortunately, we cure very little other than infectious diseases. Other than infectious diseases, we mostly help people to manage chronic conditions, or we do preventive care. But even preventive care is not cost-saving, it's cost-effective. Mammograms don't save money. It's worth spending that money in order to save lives, but it's not, doesn't save money, it's a good expense. So it remains, everybody sort of agrees conceptually that VPP is how the country should go, but there
But
is
the details on how
but
it
the
works, yeah.
details on, and especially whether or not to include some measure of utilization, and how you decide whether or not utilization is part of the UBP or is not part of it. And nobody just say that, like, no one, you say, well, then maybe we need to, be billing or at least tracking our, our emails. But no one, that seems like also going in the wrong direction, right? That's like more admin. So now I'm gonna, besides my answering the email from my patient on my chart, I'm gonna put in a diagnostic code and write a billing code. How long did it take me to write the email? That also doesn't seem like the right answer. I mean, what I most wish is that, but again, it's very hard to get to, but if you could conceptually imagine a world where everybody's health status generates a certain payment, and then they get to choose the provider, and based on their satisfaction with the provider, and if you choose John, John gets the money. If you choose Linda, Linda gets the money. If you think John or Linda isn't doing the right job for you, then choose James, right? But that the payment is the same based on whatever going into it your underlying health status is, and that would somehow be known. You fit box 11. Therefore, we're paying X amount for you for the next year, and then you choose who you want to be your provider. And therefore, the people who you could choose from, John or Linda, their motivation is your satisfaction. And they know that if they don't do a good job, whatever that means for you, seeing you weekly, talking to you on the phone monthly, whatever you as the individual consumer wanted, it's their job to deliver that, or you choose somebody else.
But let's say that consumer is in bucket 11, but they utilize John at bucket 20, right? Then, because that's what the consumer expects, even if the care is not required for, it's not changing their health outcome.
Right. Well, that again, one of the challenges about VBP that clinicians will tell you, is that the person who might be the most challenging to take care of is not necessarily the person with the longest list of chronic diseases. Maybe somebody with very difficult anxiety. It may be somebody with a terrible social situation. Things that are very difficult to capture in coding.
Right.
But you could, I mean, nothing is going to be perfect. It's trying to, I feel it's a fundamental problem of VBP that it still has so much utilization to determine the underlying rate. And that's a fundamental flaw in truly value-based payment. But I understand why that flaw exists. And I don't have an easy solution for it that works for taxpayers. I mean, it's a little easier to do on a private system, right, where you don't have to worry whether or not the payer feels they're getting the appropriate value. But again, for a Medicaid, Medicare system, nobody's going to like the idea that people are earning more than their costs. And so then if you say, okay, well, it has to be their cost, that's where the utilization comes in.
Right.
Not an easy financial problem.
It's not.
Yes. Yeah, and hopefully, I mean, they're making headway in terms of using social determinants as a predictor of what the rate should be and cost should be CMS is looking at that and signaling that they'll incorporate that into both Medicare and welcome that on the Medicaid side. So we've helped try to, participate in that thinking. Makes a lot of sense to us that we would be involved in that. I would say the other challenge in terms of providing healthcare, especially in the city, is when a patient's assigned to John, but then goes to Linda for their care, right? And that, that movement of the patient to another health system to get care is one that we're trying to, contain or control. And the best way to do that is make sure that John's doing his job and that the person recognizes that they should come to me for care in the first instance rather than going someplace else. So that's just another
Interesting, John, California did not allow that.
Right.
Because California has always been, because of Kaiser, a much more managed care world. New York is such an anti-primary care world.
Yes.
Doesn't really appreciate the value of primary care. And so here you can choose John and go to Linda for all your care.
Right.
In California, if you choose John and you arrive at Linda's office, she says, I can't see you because all your money is going to John. If you want to change to see me next month, you can, which I think a system, that's why I supported the California system.
Yeah.
You could absolutely switch to Linda in the next month.
Yeah.
But Linda was going to receive zero, if January you had chosen John and you arrive at Linda's clinic in California under Medicaid, Linda's not getting paid. And so Linda wouldn't see them. Linda would say, I'm sorry, your care is being provided by John. If you wish to switch to me, here's how you do it.
That's not
Well, that's
true here.
generally is the case here for primary care, but it's more like, I'll wait until I'm so sick I have to go to the emergency room and see Linda.
Yes, that is true. But I think, Linda, I think it might depend a little bit. I'm not sure it's an absolute, and I'm not sure it includes specialty.
Yeah.
See, ours also included specialty.
Right.
So
You could
John's
have John as your
network.
primary, but you could go to Linda's cardiologist or whatever.
I know that to be true,
Yes.
because I have patients who do that. So you could not in California do that. John's network is your network for primary and specialty. But Linda, of course, is right that under EMTALA laws, once you go to the ED, right, all bets are off. You can go. And in California, that's what we used to spend a lot of time doing, is trying to work on the ED part.
Right.
To get people. But we didn't have to do the specialty. You didn't have to. If you chose John, it was John's network.
A lot of money there moves out of the system. So it's another thing for us to try to figure out. And, we're have different thoughts in mind with Health First and Metro Plus. Because I think there's a belief, and I believe it, that, to the extent that the patient can stay within the network they've chosen, right, you have a better opportunity to provide the care that they need.
Right.
We have work, of course, to do
Yes.
to make that happen.
Absolutely.
We're
To make people want to stay.
no, to have the same waiting times.
Oh, right.
Right.
I think that's in our VBP update. We're
Yeah,
working on that.
so that, right, it's still true, and not for a bad reason, that if I schedule someone for an MRI at Bellevue, unless I think they need it tomorrow, if I thought they needed it tomorrow, I could get it for them tomorrow, no problem. And not just because it's me. Anybody would be able to call and say, this person needs to get it tomorrow. But if I'm just like,
They need to get one.
they need to get one. I might not even think they need to get one. They may think they need to get one. Okay, 2 months at Bellevue. But I could order it elsewhere, and they would get it the next day. Because most people run MRI scans for money. And the best way to make money is
To
you have
scan.
the fixed expense, and you run as much as you can.
Right.
We don't work that way. Right, we are, our scans are heavily utilized by the people rolling into the EDs, and we're focused on need. We're not focused on how do we make this MRI as profitable as possible. But if you're a diagnostic radiology group, that's your mission, I'm opening this diagnostic radiology group. I've bought my MRI, and now I'm going to go. And again, you can't blame them either. Someone has to write the order. So
There's a need for it.
there's
Demand.
There is demand for it.
Right.
Whether there is need is a different question.
Right.
It's the same thing about the same argument about the urgent cares.
Mm-hmm.
Right. As New York City has opened up all of these urgent cares. I don't know, in New York City, maybe there are 250 of them. Would you guess? I mean, I'm just thinking about the neighborhoods. Let's say there are 250 of them. They didn't exist 10 years ago.
Right.
Do you think New York City is healthier now? Do you think those 250 urgent cares have made New York City healthier? I would doubt it. There's certainly no data to suggest that we're healthier, right? And why are we not healthier? Because what are they doing? They're seeing people with URIs, with twisted ankles, the mouth sore, with the back pain, with a chronic headache. You know, there's no greater
Right.
health, and because it's urgent care, you're not building therapeutic relationships, which many of us believe do have long-lasting improvements, that getting to know people has a lasting improvement. But that's not their model. And again, can't blame them. No one forces people to go. They open up the doors. They have lots of customers. It seems like they keep opening up. There is definitely demand for it. Is there need? It's hard to say. They're certainly fulfilling their demand. People appreciate having them. I don't know. It's a hard question.
Well, this turned into a very interesting discussion and less, a lot of policy and philosophical questions that I think Health and Hospitals is very well positioned to be at the forefront of changing and influencing. So appreciate it. Thank you, Mitch.
My pleasure.
And thank you to the whole team for the update. I think this has been very helpful, and I think next month, we can dive deeper into what HMH is actually doing on VBP. So, any other questions or comments? Let me just make sure we don't have any other questions from our remote listener. And so I think if there's no old business, no new business, there being no further discussion, the meeting is adjourned. Thank you, everyone.
Thank you.